So definitely a tougher 12-lead case, and I hope we came out with the diagnosis of atrial flutter with 2-to-1 conduction. And so in the next few minutes, I'll kind of break down the case, break down atrial flutter, and hopefully the next time you're presented with a 12-lead that looks similar to this, a flutter with 2-to-1 can pop up on your radar. And so, like I said, anytime I'm presented with a 12-lead that's fast, regular, and a narrow complex tachycardia, I know in my mind it can only be one of three things. And so those three things are sinus tachycardia, SVT, and atrial flutter with 2-to-1. Those are the only three things that it can be. And when I evaluate and try to tease out which one is which, the first thing I ask myself is, are there presence of P waves? If there are in this situation, then it's sinus tachycardia. And we should be asking ourselves additional questions to try to figure out what pathology is driving the heart rate up, right? And this is typically causes that are non-cardiac in origin. This could be hypovolemia or dehydration, sepsis, anything along those lines that we should try to be evaluating for to figure out what's driving this heart rate up. If there's no or not any clear discernible P waves, then we can kind of go down the rabbit hole of discerning SVT and atrial flutter with 2-to-1. And so like I said, the purpose of this talk is to help add a flutter on your radar of potential differential diagnosis when you're facing a fast, regular, narrow, complex tachycardia. And so when I evaluate atrial flutter with 2-to-1, or I'm looking to possibly make a diagnosis, if I have a 12 lead in front of me that's showing a rate of about 150 beats per minute, usually plus or minus 10 in either direction, that's usually what's cluing me into this could potentially be atrial flutter with 2-to-1. And the reason that this happens is because the atria flutter at a rate of about 300 beats a minute. The AV node is functioning properly, and what it's doing is it's terminating about half of those impulses. And so if we're terminating half of 300, that's usually what results in our rate, or ventricular rate specifically, in and around 150 beats per minute. And we can use something known as the Bix rule in order to help evaluate for this. And so the Bix rule is kind of what that 2-to-1 conduction looks like when those P waves or flutter waves are buried and hidden within the QRS complexes and T waves, like it is in this situation. And so the Bix rule basically says that anytime that we potentially see T waves that are buried perfectly or line up perfectly between QRS complexes, that could also clue us into this potentially being that A flutter with 2-to-1. And so, like I said, in this 12 lead, we have our rate of about 150. We have those T waves, or the Bix rule, in which the T wave lines up perfectly between the QRS complexes. And it's the theory that there's buried P waves or flutter waves, one within the QRS complex and the next within the T wave. Then again, a buried P or flutter wave in the QRS and the next in the T wave. And so if we march out our P waves or flutter waves, we can see that they're at a rate of about 300 beats per minute with a ventricular response of 150. So the Bix rule is kind of that manifestation of that 300 to 150 ratio, just with those P and flutter waves buried within those QRS complexes and T waves. And so another thing that a lot of individuals like to do is they'll give the adenosine as a diagnostic challenge. We'll give 12 milligrams, we'll slow the tachycardia down, we can see the underlying flutter waves or the sawtooth pattern, and we can change and go to an appropriate management. In some situations, we can trial, a little bit of diltiazem, cardizem, sometimes a beta blocker as well, like metoprolol. And so anytime we're presented with a fast, regular, narrow, complex tachycardia, just remember it can be one of three things: sinus tach, SVT, or atrial flutter with 2-to-1 conduction.